Olfactory nerve, cranial nerve 1. Can the patient smell with each nostril?
Tell me what you smell.
Nothing.
How about this? Tell me what you smell.
I can't smell anything.
Cranial nerve 1 is often not tested unless specific pathology, such as a subfrontal brain tumor, is suspected. Impairment can be due to nasal obstruction, damage to the olfactory nerves in the nasal mucosa, damage to the nerves as they cross the cribriform plate, or intracranial lesions affecting the olfactory bulbs. Optic nerve, cranial nerve 2. Visual fields. Test visual fields for each eye by asking the patient to fixate straight ahead and to report how many fingers are being shown.
How many fingers am I holding up?
2.
How many fingers am I holding up? 4.
Visual extinction. Test for visual extinction by asking patients how many fingers they see when fingers are presented to both sides at the same time.
2 and 5.
Damage anywhere in the visual pathway from the eye to the visual cortex can cause specific deficits in the visual fields of one or both eyes. It is important to note that some visual information from each eye crosses to the opposite side at the optic chiasm. Therefore, lesions in the front of the optic chiasm cause visual deficits in one eye, while lesions behind the optic chiasm cause visual field deficits that are similar for both eyes.
2.
Extraocular movements, cranial nerve 3, 4, and 5. Check extraocular movements by having the patient look in all directions without moving their head.
Look at me and follow my finger with your eye. Focus on my finger.
So test smooth pursuit by having the patient follow an object moved across their full range of horizontal and vertical eye movements. To test convergence movements by having the patient fixate on an object as it is moved slowly toward a point right between the patient's eyes. Also observe the eyes at rest to see if there are any abnormalities such as spontaneous nystagmus or disconjugate gaze. Careful testing can often identify abnormalities in individual muscles or in particular cranial nerves. Facial sensation and muscles of mastication, cranial nerve 5 trigeminal. Test face sensation using a cotton wisp or a sharp object. Also test for tactile extinction using double simultaneous stimulation.
Close your eyes. Tell me where you feel this.
My cheek. My chin. My forehead on the right side. And my cheek again.
Good. You can open your eyes. Can you slightly open your mouth? All right. Now push my fingers down. Good.
You're going to feel the masseter muscles during jaw clench, and to test for a jaw jerk reflex, you'll gently tap on the jaw with the mouth slightly open. Facial sensation can be impaired by lesions of the trigeminal nerve, the trigeminal sensory nuclei in the brainstem, or ascending sensory pathways to the thalamus and somatosensory cortex in the post-central gyrus. Muscles of facial expression and taste, facial nerve, cranial nerve 7. So first, she's going to look for asymmetry in facial shape or in depth of furrows, such as the nasolabial fold. Also look for asymmetries in spontaneous facial expressions and blinking.
Okay. Can you raise your eyebrows? Furrow your eyebrows. Close your eyes tight. Smile. Puff out your cheeks. Blow a kiss.
No.
Facial weakness may be difficult to detect in cases where it occurs bilaterally, also known as facial dysplasia, because the facial weakness is symmetrical. Now we're going to check taste.
Stick out your tongue, close your eyes, and tell me what you taste.
Orange.
Facial weakness can be caused by lesions of upper motor neurons in the contralateral motor cortex or descending central nervous system pathways. Lower motor neurons in the ipsilateral facial nerve nucleus or exiting nerve fibers, the neuromuscular junction, or the face muscles. Vestibulocochlear nerve, cranial nerve 8. Can the patient hear fingers rubbed together or words whispered just outside the auditory canal and identify which ear hears the sound?
Okay. Close your eyes and tell me which ear you hear this.
My right one. My left one. Left again.
Hearing loss can result from lesions in the acoustic and mechanical elements of the ear, the neural elements of the cochlea, or the acoustic nerve. Glossopharyngeal and vagus nerve, cranial nerves 9 and 10.
Okay, open your mouth very wide. Now say ah 3 times.
Ah.
She's looking for the palate elevation when she says ah. Now, we would also test for gag reflex. However, this only needs to be tested in patients with suspected brainstem pathology, and that was not the case. Palate elevation and gag reflex are impaired in lesions involving cranial nerve 9 and 10, the neuromuscular junction, or the pharyngeal muscles. Muscles of articulation, cranial nerves 5, 7, 9, 10, and 12, trigeminal, facial, glossopharyngeal, vagus, and hypoglossal. We're going to be looking for the patient's speech, whether it's hoarse, slurred, quiet, breathy, nasal, low or high-pitched, or otherwise unusual.
What's your name?
Faith.
Great. Can you repeat after me? Pa, pa, pa.
Pa, pa, pa.
Ta, ta, ta.
Ta, ta, ta.
Ka, ka, ka.
Ka, ka, ka.
Pataka, pataka, pataka.
Patika, patika, patika.
Now as fast as you can.
Patika, 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 patika.
Good.
It is often important to ask whether the patient's speech has changed from baseline.
Has your speech changed from normal?
I don't think so.
Note that dysarthria means abnormal production of speech and should be distinguished from aphasia, which is an abnormality in language production or comprehension. Abnormal articulation of speech can occur in lesions involving the muscles of articulation, the neuromuscular junction, or the peripheral or central portions of cranial nerve 5, 7, 9, 10, or 12. Sternocleidomastoid and trapezius muscles, cranial nerve 11, or accessory nerve. You're going to ask the patient to shrug their shoulders, turn their head in both directions, and flex forward.
Okay. Can you put your head down and then up? To the left and to the right. Now let me see you shrug your shoulders. Good. Now I'm going to put my hand here and you're going to press against it.
Now, weakness in the sternocleidomastoid and trapezius muscle can be caused by lesions in the muscles, neuromuscular junction, or lower motor neurons of the accessory spinal nerve. Upper motor neuron lesions can cause contralateral weakness of the trapezius. When sternocleidomastoid weakness is present, there is a weakness of head turning away from the side of the lesion, which indicates the upper motor neuron lesions. Tongue muscles, cranial nerve 12, hypoglossal nerve.
Open your mouth. Stick your tongue out. Retract it. Stick it out and point it to the left. Now to the right. All right, now push against this popsicle stick with your tongue. Good.
Okay. So they're testing for any atrophy or fasciculations. They're looking for quivering movements of the tongue while it's resting on the floor of the mouth. They tested retraction muscles on the way back and protrusion muscles on the way forward, testing lateral muscles side to side. Fasciculations and atrophy are signs of lower motor neuron lesions. Unilateral tongue weakness causes the tongue to deviate towards the weak side. Tongue weakness can result from lesions of the tongue muscles, the neuromuscular junction, the lower motor neurons of the hypoglossal nerve, or the upper motor neurons originating in the motor cortex. Lesions of the motor cortex cause contralateral tongue weakness.